is the first agenda item is Dr. Sarah Schubeck, who is going to tell us about a new approach that's coming out of our women's in surgery subcommittee, thinking about enhancing our support for lactating persons on our service. Go ahead, Sarah.
Thank you so much. Can you see my slides, or I can stop sharing for Julian to share?
Yeah, I don't know who's sharing there. It looks like that's Julian's. Okay, go ahead.
Okay, perfect. Thank you so much. Thank you so much for the opportunity. This has been a kind of a labor of love, and I'm glad and appreciative of all your support. So first, just to discuss briefly the current climate for lactation accommodation at the University of Chicago. There are several spaces for faculty, staff, trainees, and family members and patients. There are several mama pods, there's several other lactation rooms, but there's currently no outpatient lactation support services. So there's certainly a lot of opportunity to improve across this, and it's become an initiative for us. We can move to our next slide, please. So peripartum considerations was raised in response to our Women's Surgeons Committee initial needs assessment in terms of kind of that whole spectrum up to and including lactation for our residents and fellows. And so we are seeking to basically improve visibility and cultural support for those individuals who choose to lactate after returning from their parental leaves. So today we're going to discuss our supportive guidelines to be adopted by the Department of Surgery. And really our goal is to normalize the need for milk expression, but more importantly, personal health choice and how we can honor that in our work environment. So we are also going to work to prioritize additional spaces in the current limitation of lactation spaces and rooms available. And we'll talk a little bit about how we're going to accomplish that. Our next slide, please. This should look familiar to all the, back one. This should look familiar to all the fellowship and residency program directors, as it was sent around for feedback and comments, and I really appreciate all the thoughtful reviews. This is our lactation support guideline, and basically what we are trying to do is highlight that we value the wellness of individuals who make this choice after returning from leave. Briefly, the highlights, this provides some education regarding the challenges of lactation in the setting of clinical training. It provides support for a lactating trainee to leave clinic, educational curriculum, and OR during non-essential times for milk expression as needed. It provides a guide for communication with team members to ensure adequate support and time for milk expression, and then allows for troubleshooting with individual program leadership if there's any concerns or challenges in obtaining appropriate time. Certainly, this is a starting point and really meant to be a notion of cultural support from a department level. And so there's a lot of work to be done, and I look forward to any other feedback once this is disseminated more widely. Next slide, please. In our future plans, certainly the Women's Surgeons Committee and the DEI group are planning to work on faculty lactation support, expand support services and access to resources, both on the inpatient and outpatient perspective, to identify and disseminate a guide to lactation spaces that are currently identified as lactation spaces, but additional flex spaces that might provide opportunity closer to clinical care environments, as that's cited as a significant limitation for individuals. And then we're collaborating with the Women in Medicine and Women in Pediatrics groups to highlight other supportive opportunities that we can work together across the institution. And finally, our last slide, I just want to say thank you to everyone for their support of this work. I think it is a really important step forward and certainly can then translate to other health needs outside of lactation. So I'm happy for any feedback via email, and I look forward to continuing this conversation.
Great, thanks so much, Dr. Schubeck. That's important. If anybody has any questions or comments, put them in the Q&A, because I think they're easier, they can be seen by everybody. I don't see anything in the chat or the Q&A right now. So, but if that comes up, go ahead and type away, and we can circle back to this. But thanks so much for your leadership on this, Dr. Schubeck. This is really important work.
Thank you.
Okay, the residents can drop off and go get the day started if their schedule needs it. But everybody's welcome to stay for the rest of the meeting. Next, we have Kathy Vandenbroek and George Wire, who are going to talk to us about value-based care and some new things that are afoot. I don't know what George or Kathy, who's
yeah, thank you for having us today. So we are going to talk a little bit about value-based care. So there is tremendous growth across the country in value-based care in our market as well. And these models look very different from fee-for-service, which you all are used to. So we are spending a little time with departments talking about strategies for success under value-based care models. So to start with, we'll just spend a minute on the definition of value-based care. So these are healthcare models that tie payments for care delivery to high quality service and access, all while controlling cost. So high quality, controlled cost. CMS says that all Medicare payments will go through a value-based model by 2030. So we know there's going to be continued growth over the next few years. And as of 2023, all the commercial contracts, the major ones for UCPG, will have a value-based term in them. So important both for our government payers and for our commercial payers. Today, with the time we have, we're going to talk about the Medicare programs, the major Medicare programs. So to start with the Medicare Shared Savings Program, we have about 10,000 members in this program. The CMS considers this an alternate payment model for hospitals, physicians, providers that promotes high quality, low cost, so our value-based kinds of terms. To participate in MSSP, you have to be part of an accountable care organization, which we are. And if you participate as an ACO in MSSP, you get the traditional fee-for-service payments. But in addition, you're eligible to receive shared savings on top of that. We have not at UCM historically received shared savings. We've been in this program for over 5 years now. At first, we had huge deficits, and then recently we've gotten it to the break-even point, and we're hoping to get some shared savings next year. This is important to us because our Medicare fee-for-service payments are below cost. They're really low. So we need to figure out how to get some of that shared savings in this program to bring our payments up above cost. The other major Medicare value-based program is Medicare Advantage. You may be seeing some of these programs on television with United and Humana. They're all promoting these Medicare Advantage plans. So these are commercial payers, private carriers that manage Medicare benefits for Part A, hospital, Part B, physician, typically Part D. So they bundle it all together. Medicare pays these commercial carriers on a per member per month basis. And those commercial carriers like to turn around and pay providers like us on a per member per month basis so that we share risk and there's some encouragement to hold down cost. So we're basically put on a budget and we need to manage all the costs of care within that PMPM. Now, there's two important methods for increasing funding in Medicare Advantage. First, if you have strong quality measures, you can receive some additional funding. Second, and very importantly, which we're going to focus on today, is the risk adjustment factor. So you get this is a risk stratification method. CMS calls this the CMS HCC hierarchical condition category score. They like to make it complicated, but it primarily uses diagnosis coding to adjust that per member per month for higher risk populations. So we are going to focus on that today. And I would just say it's similar to under fee-for-service where, you know, CPT coding is the way to make sure you maximize your reimbursement. In value-based care world, diagnosis coding and RAF score is the way to ensure your funding levels. So we're going to talk to you today about that with some specific tips for surgery. So that RAF score is really important for academic groups like us because we tend to have a more complex patient base. So very important for us to get the funding we need to manage a complicated group. So the national RAF score is 1.0. We are currently about 1.1 to 1.2. Which is not really adequate to cover a complex patient base. Academic groups that are coding well and accurately are in the 1.5 to 2.0 level. So that's a significant, that would be a significant bump for us. So that's the territory we're looking for. Some challenges with the diagnosis coding and the RAF score. Only diagnosis codes carrying an HCC weight add to that RAS score. So this is important. Not every diagnosis code carries an HCC weight, so important to know which ones do. And they need to be redocumented every year. So that RAS score goes back to 0, January 1st, and you have to redocument. Important to note, about 6 months ago, we had Epic upgraded to include the identification of HCCs in the diagnosis dictionary. So you'll see next to diagnoses in Epic, in parenthesis, the CMS HCC designation next to the ones that carry that weight. So I'm going to turn this over to George at this point to talk about, from a provider standpoint, what this looks like and some tips for your department specifically.
Hi, everyone. I'm George Wire. I'm one of the primary care clinicians and also one of the medical directors over our value-based care programs. Thanks for taking some time today. This slide is just highlighting for you some of the changes that occurred in Epic. I'm sure many of you have seen these. Essentially, anywhere you can identify ICD-10 diagnoses or problem statements, Epic adds this little tag to the end of any diagnosis that would be relevant for this Medicare risk score. So look for that CMS HCC tag. It's important because often if you're working with a rather unspecified or symptom-based description for your patient's concern, and there would be a more appropriate, more specific term that has a CMS HCC label behind it, it's important you try to move and select that more specific option to communicate the risk to Medicare. One other point is that Medicare doesn't get any information that is not included on a claim. So you may write a wonderful note. You may have a very accurate problem list in Epic. Those two things are very useful for us in terms of the clinical care we provide, and they're a good jumping off point for getting onto a claim. But unless it gets on the claim, Medicare doesn't see it. And so the really critical thing is that we move these diagnoses codes into visit diagnosis during like ambulatory encounters, for example. So that's the really critical point. So keeping up-to-date records and then moving those diagnoses onto visit diagnosis at least once a year maintains the risk adjustment for those conditions. Next slide. This is a list that we took from Department of Surgery's billing record, showing you kind of the top 20 diagnosis codes that are billed by all members of the Department of Surgery. And respectfully acknowledging that there exists a tremendous diversity of clinical portfolios in the Department of Surgery. So this is kind of a big jumble of diagnosis codes. We'd be happy to provide sort of more section level information in the future if that's something that anyone would be interested in reviewing. But we've highlighted here the ones in yellow that do impact the CMS HCC score. So there are a large number of diagnoses that are relevant. A couple of just things that jump out that we'll talk about in the next slide that are going to be common coding scenarios that there could be pitfalls for across the department. So next slide. This is more general information for the whole health system, showing you the kinds of diagnoses that we collectively know that we underdocument, undercode. A lot of these are related to diabetes. One of the challenges we have in the health system is that we don't tend to document the complications of diabetes. Certainly, surgeons do deal with those complications at times. So that would be one way that you could help the overall health system. Additionally, things that can be forgotten about, things like obesity, chronic kidney disease, things like that are often not coded for. Some basic suggestions that are sort of we hope will be generally applicable to all surgical subspecialties include the fact that you can document important comorbidities. Conceptually, if you're preparing for a elective surgical procedure and your patient has important comorbidities that are influencing the preoperative surgical risk, you can go ahead and code for those things to sort of be more descriptive. You don't have to be sort of managing the condition directly to be able to add that diagnosis code to your encounter, as long as it's influencing the care you're providing for the condition you are managing. So common things would be, diabetes, obesity, lung disease, heart disease. Being specific about those codes would be very useful. The next thing that's common across multiple surgical specialties is cancer coding. And here the risk for us is that we tend to overcode for cancer, meaning that we add an active cancer code and don't remove it when it's no longer appropriate. CMS has basically 2 simple rules for solid tumors that give us guidance about when we can use an active cancer code versus when we should be using history of cancer. And the 2 rules basically are that you can use active cancer codes when, one, you either know that there exists cancer tissue in the body, or 2, that you're providing, the patient is receiving ongoing treatment that's directed at the cancer. So if one of those 2 things is true, you can code for active cancer. If neither is true, then you need to use history of cancer. Transplant's another example that would be common in the surgical subspecialties, where there is this sort of progression of codes. If you move from end-stage renal disease, that's a risk-adjusted diagnosis. But for example, the actual kidney transplant itself is not weighted as an HCC diagnosis, but capturing the like immunocompromised status because of medications, or any subsequent chronic kidney disease and the transplanted organ, those would all add HCC weight. So it's important to document the complexity that follows the transplant to maintain risk adjustment. Another just basic thing that we ask for specialists is to encourage patients that you're following closely to make sure they see their primary care providers. We do work a lot with primary care providers on these topics. We've been working with them for years on this, trying to promote comprehensive coding, and you rely on our PCPs to be very comprehensive in their coding. So seeing the PCP can be a way to really make sure that everything's been up to date. This is just the last few points. Again, your visit diagnosis is what's transmitted to Medicare on the claim. So that's at the end of the day, what matters. We do want the note to support the visit diagnoses. You can use more than 4 diagnoses on your ambulatory visit diagnosis. That's fine. We can transmit additional beyond 4. I know that's been historically something that was taught to limit to 4. You can use more if appropriate for your patient. For telemedicine visits, video-based visits count for risk adjustment, but telephone only do not. So I think we all try to use video when we can, but this is just another reason why video visits would be preferred. And then the basic requirement for any documentation is that we have some kind of neat content for each of the problems we have on our visit diagnosis. So some sort of assessment or plan related to the diagnosis. I think that's the end of our slides. There was one question. Mechanism for section specific support. We'd certainly be happy to prepare a more section level of review of diagnostic coding opportunities. I think because of the diversity in surgery, that would be really helpful. And there exist a number of different departments that are available for coding education, compliance review. So we definitely would be happy to link anyone that's interested with additional support.
Yep, just let us know if you would like a section level presentation like this with very specific information for the section specialties. We're happy to do that.
I think one of the opportunities might be, Kathy, if we could get that section level education with a little bit more lead us by the hand a little bit, exactly which buttons we're supposed to click where,
Sure.
with some actual examples. This is not, as Dr. Donington points out, this is foreign to a lot of what we do. And so just finding out how we can optimize this. Vivek, do you want to make a comment on this related to some of our other risk adjustment activities and the smart forms that you've been developing? Maybe we can get a discussion and some follow-up going on that.
Yeah, for George and Kathy, one of the things that we have that's like literally ready to go is we have something called a surge risk smart form that captures the variables used by the NISQIP program to do clinical risk adjustment. And so with this form, we could potentially capture a whole host of these comorbidities, which I think there's substantial overlap with what these HCC categories are. So there is a query that's out there with medical records because we've shared this with them to try to get some clarity as to whether, if we decide to do this as a department, whether this would meet that documentation requirement, because that might be a much simpler and frankly surgical centric way for us to do this, because I would say that most of us don't use probabilists and so forth the same way that primary care does in our clinical practices.
Yeah, I'd definitely be happy to follow with you on that. Sounds like that'd be a way to really cover, a lot of the diversity in surgery very quickly. We'd be happy to help you review that with compliance. I think it's going to come down to kind of what the content looks like in the note and sort of how much it, would meet those sort of meet requirements. But that sounds very interesting.
Yeah, I think one of the things that we're trying to triangulate between, George, is that we have this imperative to do better documentation for U.S. News and World Report. We have this impetus to do better in documentation for value-based care, and we have our complications reporting, which is done through NISQIP, and none of those systems talk to each other. And there's great ambiguity as to whether there's a single solution for this. And Vivek has proposed something that just comes out of a dot phrase, and we can't get any traction in the institution as to whether this is better, rather than learning 3 different approaches to try to do this documentation there. The other challenge that we have is that, and this is Neil Hyman asked a question in the chat, which is, where does this coding actually happen? Is this in the ambulatory, outpatient setting? Is this the onus on the attendings to be doing this? If the house staff are doing it, this is often, the note from the intern who's not an expert on coding in any of these areas, and they rotate to thoracic 1 month, and as Neil says, then they're colorectal the next month. And so how do we
so provider documentation or provider coding in both inpatient and outpatient settings does both matter. I think in the inpatient setting, there's some of the prompting that happens to assign diagnoses as you're adding your level of service codes for rounding or for procedures. On the outpatient, it really is the visit diagnosis field, and whoever is populating that during an ambulatory encounter is the one that's basically doing the work for HCC coding. Oftentimes that's added if someone's trying to order an imaging test or a laboratory test, they'll add a visit diagnosis. So it depends on, at what point the attending gets involved in surgical encounters and if they're reviewing those visit diagnoses.
I can tell you they probably aren't. And it's just not something that's going to happen. So we have to figure out a way to solve for this. One of the other problems or questions that came up that we need to have an understanding of is, at some point in time, a patient sees their internist, then or some other medical specialist gets sent to us. And now, do we have to do everything again, or is it already done for the year? And if somebody is incomplete when they put in a CAT scan request for the visit diagnoses, does that reset everything? And are we now, or does every diagnosis, every encounter need to be redocumented again? Because we have ambulatory, then they come back for their HMP, inpatient operation, and we can't.
Obviously those are great questions, and a good point in the chat about this sort of the documentation burden. And obviously there's a really big push to make sure we have timely note closure. So these are running kind of opposed to each other. It is just one time per calendar year that matters. And it could be the internist that does it. That's sufficient. No one else would technically be required to do it for the year. So you aren't obligated to diagnose every diagnosis at every visit. I think that, I think it's really important that we, take a look at Vivek's proposal and try to see if that would be an efficient way to make this more streamlined for surgical providers. There certainly are ways in Epic to do auto documentation. That's something that's been used more extensively in the inpatient, where note content is sort of generated algorithmically, and diagnoses can be sort of auto assigned. So I think that there is a path forward that we can make some of this much simpler for providers.
I think that's going to be really important. It's unclear, when does this get saturated? After 4 diagnoses, or the correct 4 diagnoses, the highest level? We see a patient then who's got a new diagnosis of cancer. Now we're adding that to their, CKD and their diabetes and all of this. Does that change anything, or is that already?
Absolutely, yeah. So the way the risk score works is that the 10,000 plus ICD-10 codes are boiled down and matched to about 80 diagnostic categories, and patients can accumulate additional risk points if they add additional categories. So cancer would be a new category of diagnosis in that case, and would result in a net increase in the risk score. Having multiple different solid tumors, probably, it would have a more muted impact, just as like having 4 or 5 different kinds of CKD diagnoses wouldn't really result in a net change because you already have the CKD category added to the risk portfolio. But any additional disease categories that are added do add additional points throughout the year.
Dr. Agarwal asked a variation on what I asked. If it's documented in the ambulatory encounter, does it automatically carry over to peri-op and to inpatient?
Yeah, again, so Medicare is going to review all the provider claims they get in a calendar year, and they're going to just throw all those diagnoses into a bucket, and you're going to use every one of them. So it doesn't have to be repeated continuously throughout the year. And it's the cumulative diagnostic record that's developed over the course of a calendar year that results in risk coding for the next year.
Great. There's another question. Are our primary care colleagues using the annual wellness visit option to through Medicare to document the HCCs?
Yeah, absolutely. That's been a big initiative for us over the last few years. We're certainly not to the point where we're doing that 100% of the time, but we've been rapidly expanding the use of annual wellness visits and focusing on that as a risk adjustment strategy.
Okay, great. Thank you very much for this. This is a good presentation, very interesting for everybody. We'll have to have some further discussion and perhaps some section-specific initiatives. We'd love to see some follow-up on that surgical risk tool that Dr. Prashant has developed. We're not going to be able to get, thanks so much. We're not going to be able to get through this entire agenda today. So I do want to, can I just jump to faculty news, Julian, because I want to make sure that we introduce some of our new faculty and just, go back to, my kudos or something, wherever is that where we're starting? Okay. So heads up, everybody, Thursday, October 26th, we're going to be doing our annual department photograph. Stay tuned for that. It's going to be from 5:30 to 6 in the evening. We're going to hopefully get as many people as possible to come for that. It's going to be over in Mandel Hall, which is where it was in this wonderful unmasked photo from a year or so ago. Next slide, Julian. I've had some promotions and some new hires. This time of year is often so many new people coming on board into the department, and I just want to run through those all. And let's first start with the promotions. We want to congratulate Dr. Andrea Shogan, who was promoted to associate professor. Congratulations, Dr. Shogan. She was also elected to the faculty practice plan, which is another big deal. So we really appreciate her accomplishments and her contributions. Next. And Dr. Diego Di Sabato in transplant, one of our busiest transplant surgeons, was promoted to associate professor. And again, congratulations. A lot of work done over the last couple of years in elevating our programs in living donor transplantation that Dr. Di Sabato has led. So congratulations, Diego. Next, let's run through some of the new faculty appointments. Dr. Vanessa Bowie stayed on with us after completing her chief residency for a year as a clinical associate. She's been extraordinarily busy already doing general and MIS surgery and RACS call and before she heads off to her MIS fellowship. So congratulations, Dr. Bowie. Next. Bill Gao joined us in otolaryngology. He is going to join Brandon Baird in our laryngology program here. We're really excited about his arrival. Welcome to Bill. Next. Joe Maleka in otolaryngology also is our first facial plastic surgeon and reconstructive microvascular surgeon in head and neck. And so we're really excited to expand that program. Very, very important to the OHNS training programs. Welcome, Joe. Next. In pediatric surgery, a few new appointments in pediatric surgery. Dr. Mubina Asani joins us from CHLA. and UNC, and just finished her pediatric surgery fellowship at Nemours, and joins our section of pediatric surgery. Next. Charlotte Kasnowski is joined us as well in pediatric surgery. She's got a MPH from Emory and PhD in biostats that she received at King's College in London. And she finished her pediatric surgery training at Northwell, and she's just joined our faculty as well. Welcome to Charlotte. In plastic surgery, Dr. Courtney Cripps has joined. She finished her training at Lenox Hill and then NYU, and she's specializing in all aspects of gender affirmation surgery, as well as body contouring and other general reconstructive plastic surgery work. She did a great job even before she hit the faculty of helping us in our DEI session over the summer on transgender health. Welcome, Courtney, officially. Next. Also in plastic surgery, Dr. Mark Tan has joined us. Was a busy cancer reconstructive surgeon out at the City of Hope, and he's relocated here with us and has already hit the ground running. He's microvascular trained, very busy reconstructive surgeon, very important for our breast and lymphedema programs. So we're excited to have Mark here. Next. In urology, Ted Skolaris joined us as a professor, and he is joining us to set up our program in health services research within the department. He's our new director of implementation science and health services research. His office is actually down here in the central departmental suite to facilitate the ability to work with all sections and everybody interested in health services research, and also to be closely connected to our research infrastructure. He is an incredibly well-funded investigator from University of Michigan. He's a urologic oncologist and does very interesting work in prostate cancer survivorship. And if you actually follow the thread between Dr. Charles Huggins' Nobel laureate work, straight line to the work that Dr. Skolaris does. So it's really very appropriate that he's here and going to really jumpstart and accelerate our work in health services. Next slide. I think there was then Dr. Darren Bryan in thoracic surgery returns to us after his general surgery residency here in thoracic surgery fellowship at the Brigham to specialize in lung cancer and mesothelioma. And we're really excited to have Darren back. Next, I think that was it. Was that it? No, I forgot. Ariel Semino in transplantation has joined us. She just finished her transplant fellowship at Emory and after receiving her general surgery training at Maryland, and she worked with Robin Pearson doing xenotransplantation research while she was at Maryland, and she's just joined the Transplant Institute in the section of transplantation surgery. We're excited about her future here. So welcome, Ariel. And was that, yeah, we got Ryan Boudreau, also a new trauma surgeon, has joined us in trauma and acute. A lot of faculty coming on board. Ryan comes from his residency and research fellowship at University of Cincinnati, holds a very dear place in my heart. And we're really thrilled that he has joined us. He trained at LSU, so we've got really robust surgical critical care and trauma training. So welcome to Ryan. And I'm pretty sure that's it. Yes, yes, okay. We'll leave the accolades as usual. We'll circulate them, and we'll send them around so everybody can read them. Let's go back to the agenda, and can we go to the research report? Dr. Alberti and Janine Grohar are going to update us very quickly on what's going on in research.
There we go. Excellent. Thanks, Jeff. So I'll be brief, and I want to thank Janine Grohar for putting these slides together for us. You can see here our research highlights. I'm just highlighting two among the many of our outstanding rockstar grantees, Dr. Luca Pasavacek here and Dr. Tanya Zacherson, who both have received awards recently that increase our portfolio. Grant proposals submitted continue to accumulate and rise at a very high rate. We thank everybody for their efforts in this regard. Next slide. I won't repeat what Jeff said about Dr. Scolaris, only to say that we're developing a health services research core as well as an implementation science core. There's a strategy meeting, that is actually underutilized. And we should all, those of you that want to jumpstart your research project should consider presenting at this meeting. I think it's very valuable to get feedback from us. Remember, save the date for the Huggins Symposium. I know it's way off, but it's March 22nd. Please mark it in your calendars. And always keep in mind that we have two biostatisticians, 50% each for the Department of Surgery, so 1 FTE. Thank you. Next slide. And finally, just for you to understand that our research portfolio continues to grow. We're actually in the $10 million. We don't have all of our notice of grant awards back in yet, but we are in the $10 million range, which puts us in the position in the Blue Ridge Institute rankings, among the best of the best, which are, Duke, Penn, Stanford, Michigan, et cetera. So thank you to everybody for your efforts in working hard to submit your grants. I know it's a lot of work, but the work is being appreciated by the department and visible in terms of our ranking and total dollars brought into the department. Thank you. And I'm done.
Great, thanks so much. Okay, we have two other quick reports. Let me, I don't know if we're going to get to all of them, but let's see. Vivek, do you have slides for your quality update? Perhaps you can be brief.
And I'll be quick. So
just to interrupt just for a second, John, I'm going to have to drop off because I got to lead a Zoom meeting. It's starting at 8 o'clock. So can you finish? I'm going to drop off at 8 o'clock. If you can finish, please. Go ahead, Vivek.
Okay, so one of the key components of our SSI reduction bundle is the use of chlorhexidine treatments the night before surgery and the morning of surgery. And so we have ability to track that now. The pre-op nurses record whether the patients actually did the treatments. And I'd just like to highlight the fact that less than half of our patients are actually getting both the night before and the morning of treatments. And this is specifically for patients that are elective cases. And so one of the strategies that we've used in our group's practice is when our nurses call the patients a couple days ahead of time, to also remind them to use the wipes the night before. Next slide. And I'll show you just even with my own patients, this is my data with the cases. You can see in that graph.
The slide didn't advance. Did the slide advance on other people's screens?
It's advanced. It's a subtle difference because this is just my patients instead of the department.
I see. Okay.
You can see that trend with those graphs towards the end that with just a little bit of nudge from our nurses with the phone call that we can actually make a difference. So I'd encourage that information to be shared during those check-in calls a couple of days before surgery. Next slide. Okay, next slide. And then, as discussed during the M&M this morning, I think that as a department, we really need to take advantage and frankly implement a regular post-discharge phone call to our patients to take place between the time of discharge and when they come in for their first post-op clinic visit. This is a key part of our enhanced recovery protocols, but I think that that communication can certainly go a long ways towards identifying issues and lead to a triage either in the care transitions clinic, avoid ER visits or readmissions. I think just from a patient satisfaction, having that additional touch point of care so that patients understand that we care about them, not just when they're in the hospital, not just when they're in the clinic, but in between. I think that the best approach is to use our nurse associates, our APPs who know the patients from preoperatively. Although I think that there are some opportunities for resident and fellow involvement, service by service. With enhanced recovery, there's a discharge template phone call that's available, but obviously this can be modified in a specialty specific manner. And happy to have conversations or discussions, answer questions offline. Thanks.
Thank you, Vivek. Grace had to drop off, unfortunately, because of the hour. So why don't we have Doug, do you want to give us a quick financial update in 1 minute or less?
Yeah, I'll do it really quickly. So generally speaking, I think it's important to understand that our visit volume is down from previous year as well as budget. I think we can attribute the vast majority of this to what we saw earlier in the slides, where we have a large proportion of our faculty that have just started in the past quarter, some of which have only had a couple of weeks with us. And we had some earlier than anticipated departures of other faculty post-budget. This is not an issue to be concerned about. We actually feel like we'll see some substantive recovery for this over the course of this existing quarter. And when we report out in Q2, we expect to see some improvements in that. Next slide. Interestingly, though, even though visit volumes, new patients, as well as all other patient volumes are down, our cases are actually quite favorable to budget and to prior fiscal year. And this actually doesn't include any of the offsite work that we're doing, which would show that our total case growth as a department continues to climb substantively. Some of this can be attributed to the complexity issue, so inpatient versus outpatient. We're doing a few more outpatient cases. There's some other areas where we have seen case growth that might not have been expected and might not be as closely related to new patient encounters as what we've seen in the past. So we are working to reevaluate this, but overall cases are up. So
Great.
That's it.
All right, thanks. Thanks a lot, Doug. So, I can see a lot of people are dropping off because the hour is late. So why don't we adjourn, and thank you everybody for your attention and time.
Thank you.